It is now 11:04. What day is it? April 16th, 18th, sorry.
Today's Friday.
And we have in with us, Agency of Human Services. We're sticking with section 2 and 6 right now, which I do realize that you all aren't a huge part of. Believe me, we're gonna have you back. So, welcome. Thank you.
Yeah.
And really looking forward to your comments on this.
Sure. Thank you for having us. For the record, my name is Monica Ogilvy. I'm the state Medicaid director. I'm also part of the executive leadership team at the Agency of Human Services, and provide a great deal of support to for the departments at the agency, including the Department of Disability Agents Independent Living, Department of Health, Department of Mental Health, and the Department of Vermont Health Access, as well as our healthcare reform team, which includes everything from field services to BCCI to blueprint and health reform. So delighted to be here. With me, I have.
Hi, everyone. For the record, I'm Sarah Rosenblum. I'm the Deputy Director of Healthcare Reform at the Agency for Human Services.
And I recognize that Sarah was here last week with our colleague Alicia Cooper from the Department of Vermont Health Access. We are really just here to answer any lingering questions you have left from testimony last week or new ones that have popped up and bubbled up. We're generally really supportive of this legislation. We have been working really hard and really well with Green Mountain Care Board, Healthcare Advocate, other community partners to really think about how we can move some of this work forward, and are feeling really confident and excited about some of the progress that we've made. Recognizing that there are hard decisions in front of us, probably related to this legislation, related to things that might come down from the federal government as it pertains to our Medicaid program and other benefits. And so whatever we can do now to put a framework around how we want to improve access and affordability to healthcare, now is definitely the time. So delighted to be here to be a resource for you.
Okay. Does anyone have any questions? I know that, yes, Tucker.
What do you call it? 10? What's
Ahead.
ahead? What's going on with that?
I'm so glad you asked that question. So no, it's a really, really fair question. We, for a while, and this is pretty typical for a change in federal administration, things went pretty quiet with the federal administration and our partners over at CMMI, which I'm using an acronym because I don't remember what CMMI stands for.
The Center for Medicare and Medicaid Innovation.
Thank you. We've now been back in contact with them. We've heard some small changes that probably wouldn't surprise you. E used to stand for equity. Now it stands for efficiency.
Sorry. Oh, my God.
That's okay.
What is that? AH.
Oh boy, that one's harder. States advancing
Health.
health
Efficiency.
efficiency. It is still technically equity in the name of the model. It's just that throughout the.
It's advancing all payer
Thank you.
health. H
Oh, my God.
and health, moves to health efficiency with you. Approaches and the DO co-op.
We certainly did not prep this for testimony. We will get back to you with what it's.
I didn't even know what it
And-
was. I said
Development.
That has a nicer ring to it. So, I think some of the elements of what we negotiated are a bit back on the table. And so we're really just doing our due diligence to make sure that it's the right thing for Vermont. We are also hearing from the federal government that they are committed to trying to infuse money into states for really critically important initiatives. And so we would hate to not take advantage of that if there's an opportunity and pathway forward. So we're taking a little bit of time to reassess what the new model or what the different elements might look like. Yeah, of course. Thank you for the question.
Wait.
Since we were talking about ahead, what could you tell us
So glad you're here.
about OneCare? How is that coming along with the shutting down and its continuation until
Sure.
the ahead model comes forward? If
Yeah. So We have been working closely with OneCare to fully appreciate all of the different bodies of work that they do on behalf of the state, the healthcare system, and certainly on behalf of the Medicaid program. Because, you know, there's mechanisms for getting dollars out the door, but there's also some really robust and incredible data analytics functions that they perform that have been incredibly helpful for healthcare providers from what we've heard from them. And so what we don't want to do is lose any of those really critical functions that have been helpful in this work. And we would want to maintain those moving forward. And so we're really trying to work out how we're going to have the resources to maintain those key gaps that are going to be missing. Not a ton, but what we do stand to lose could be quite meaningful. And as you know, we've talked from a budget perspective about how some of the gap funding could be approached. Yeah.
Leslie, can you speak about the gaps? Like, are there a list or something that we could learn?
I think we've provided that to the
Okay.
committee already. I didn't come prepared with that information. We'd be happy to resend it.
Yeah, I think that would be helpful. I don't recall seeing it, but I missed
Was
it.
that in our budget discussion?
It was. Mhm.
Sort of the bridge funding.
There was bridge funding, but
And it listed out, you know, there's a handful of programs, SASH, Blueprint, for example, things
that's what you're
that,
talking about. When
Yeah.
you say gaps, so that's what I'm not clear on. When you say gaps, what are you referring to?
yeah. So there's some operational functionality that OneCare performs on behalf of the state and for the healthcare system. Yeah, there's a handful of elements. We'd be happy to follow up with some detail in
That'd
writing.
be helpful to me, sorry.
No.
What happens if we don't have a head?
It's a great question. You know, I think that there's some really wonderful elements of AHEAD that we wanted to leverage. If it doesn't remain the model that we think is best for Vermont, then I think that we'll have to make some decisions about that. But AHEAD was never intended to be all of transformation. It was intended to be one part of some of the transformation work that we've embarked on already with Green Mountain Care Board and other partners. So, you know, there's a handful of things that we could stand to lose if we don't have AHEAD. Are there any specific details you want to speak to?
Well, I was just going to say, I think S126 does try and, leave the door open. If we want to do AHEAD, S126 aligns with AHEAD. If AHEAD doesn't move forward, things like a hospital global budget are still going to happen in the state, just not through AHEAD and not for Medicare, but are going to happen through commercial. So I think there was intentionality in developing S126 that it wouldn't conflict with AHEAD. And that if AHEAD is no longer the right fit, that we do have, I view S126 as the pathway of what happens if we don't have AHEAD.
That's really helpful. Thank you.
Can
Yeah.
I ask a clarification because this has come up the last day or so? When you say global hospital budgets, are you referring to global payments or you're referring to
Budget.
budgets?
Yeah, and I would say one space that we have flagged of misalignment is the timeline for implementation of hospital global budgets as outlined in S126. And I appreciate that it's a big body of work and that big bodies of work need time to do well. The state already implements hospital global budgets through Medicaid for hospitals. We've been doing it for over a decade, has worked really well. If we could do that sooner in S126, I think that would be optimal for the healthcare system. Reference-based pricing is a great start, but as you heard yesterday from Dr. Loeffler, it doesn't necessarily control costs per se. So it's really that hospital global budget that's that mechanism to help support cost control. So this has us implementing hospital global budgets a little bit later than we would have seen with AHEAD.
I think I'm confused. So hospital global budgets essentially that's what the Green Mountain Care Board is already doing by setting the patient revenue, net patient revenue. They're essentially setting a hospital global budget.
Talking about commercial payers, which is what is covered in S126.
Well, so you say we're already doing that with Medicaid.
Yeah.
What does that look like in practice? What, are you just giving hospitals a lump sum? Or are you giving them you're just giving them essentially how much they get for each service they provide. Well,
It's more complex than that. If you wanted to talk more about the details about that, we would have to defer to Alicia Cooper, who was here last week. She's the one who's overseeing our methodology for establishing hospital global budgets, which has some reference-based pricing baked into it. And so that's what we, so Medicaid, if you think of Medicaid in this context as an insurer, obviously Medicaid's much more than that. What we're talking about, one of the key elements in S26 is 126 is the same for the commercial payment side.
okay, I'm still confused because it sounds to me like we're talking about global payments.
Our terminology is hospital global budgets.
And that's what we're finding in this committee, that there's confusion over what everybody's definition of what a global hospital budget is, that some people are referring to it as here's your budget. And then some people are referring to it as a global payment. Here's your payment that you're going to get. And so we're trying to distinguish between, in this bill, using global budgets. What does that even really mean? Because it means different things to different people.
Yeah, we would be happy to have Alicia come back in to talk more about what the hospital global budget methodology and what that looks like in detail. And the Medicaid program side looks like. And that's what we would be contemplating is happening for commercial payers in this.
Okay, I think we need to, we're gonna need to do that because we need to use the right language in here so that everybody's working under the same.
Yeah, we're really comfortable with the language in here as it's used hospital global budgets. That would be consistent with what we've been doing for about a decade.
Any other questions? I have a question about I always go back to this number 5. I'm just now referring to it as number 5.
Yeah.
So at the end of section 3, the last, it's the last paragraph and I'm sorry, I'm working off of a different version, so I can't reference a page number for the rest of everyone. But it has to do with the Agency of Human Services in consultation with Green Mountain Care Board may implement reference-based pricing for services delivered outside of a hospital.
Yeah.
So
I get it.
we heard testimony. Well, first of all, my question was, what does that even mean? And doesn't AHS already do that effectively in the Medicaid program? Because DIVA essentially kind of pays reference-based pricing. But also the Green Mountain Care Board advised us yesterday that they actually already have this authority to set reference-based pricing for the larger system of care, not just hospitals. So I'm wondering your feelings on, is this something that you should even be doing? Or is this something that should go to the Green Mountain Care Board instead? And what is your interpretation of what this even means?
The Agency of Human Services already does this in the Medicaid space. We would not advocate that any of that change. So Agency of Human Services has authority over Medicaid. We've said pretty clearly all along that we want to maintain authority over Medicaid and that if we're contemplating more authority over changing payment methodologies for commercial insurers, that would not be within our purview. But that we would want to maintain the Medicaid, which would be consistent with what we see nationally. It would be pretty unprecedented for that to change. Overall with this, we're neutral on this section. But we do see some potential value in keeping it, just in terms of thinking about how we've heard from the healthcare system, payers, et cetera, that parity is important and alignment in the models and that the way we pay healthcare providers is really helpful to them. And so a lot of what we're doing is trying to make things the same in how we pay for services and pay providers. It reduces confusion. It just makes things more straightforward. And so we can see some value in leaving this because it helps pave the way towards that, just through that mechanism that we would be in consultation. But I would say overall, we're pretty neutral on this section. Do you have anything to add to that?
I don't think so.
Okay.
I think I'm just very confused because the Agency of Human Services in consultation with the Green Mountain Care Board may implement. It's the implement.
Yep.
So you already implement it for Medicaid. That's not an issue. This seems to imply that you're implementing it for the commercial space.
Right.
And I'm trying to figure out how that would even work as AHS doing that.
Yeah, we're not necessarily seeking authority over anything commercial related. So that's not our understanding of this, but
But I agree with your interpretation that the way that that paragraph
Yeah.
makes sense is if it's talking about commercial, because it doesn't make sense in the context of Medicaid where we're already doing it. So we agree with you that, and we've understood that I think the intention was for that paragraph to be about commercial, but I echo Monica's point that
yeah,
we're not actively seeking that.
I'm just trying to figure out how it would practically even
yeah.
work. So if that was changed to the Green Mountain Care Board, you would not have, you would not argue against that?
I think it would just have to be clear that it's not related to Medicaid. I can't say for certain. It would be good for me to sit down and think about that prior to committing. Because more brains are better than just one.
Okay.
Yeah, I hope overall we're neutral about it as it is. So I can certainly appreciate where the confusion comes from.
Pepper.
Is there any stomach for having some kind of waiver from the federal government so Medicaid could be included
Medicaid included in what?
in reference price financing all the global budget?
Medicaid already implements reference-based pricing and hospital global budgets. We already do that on behalf of the Medicaid program. We wouldn't need a waiver. We already have authority to do that. We already do it
You already do that.
for the Medicaid program.
I think I think it's even more important, I think, we get the definition that we're gonna use correct. And how it's used.
And who's doing it?
Mhm.
And who's doing it? And for what,
who's doing
and for what purpose?
Yeah, okay.
I agree that needs to be fleshing out. Brian.
Yeah, that just prompted me I just thought of a question and I don't want to spend too much time on it, but I'm curious how Medicaid does that. Like, is it federal guidelines? Is it a waiver from the past? Is it like, how did the Medicaid program in Vermont come to use the practice of reference-based pricing? If you could just briefly tell us.
I'm probably not the right person to answer that question, but I can tell you we have authority within our 1115 waiver.
Okay.
And we've been doing it for a really long time. And so, of course, we have a budget that we have to operate within, right? So we do try to look at Medicare rates, which is where the benchmark that's set by which prices are referenced. So when we say reference-based pricing, they're talking about in reference to the Medicare benchmark. And so we're kind of always assessing where our Medicaid rates line up against Medicare when there's a comparison to make. Where the non-hospital services always get a little bit confusing for people is because there's not always a lot of Medicare benchmarks for us, especially when we're talking about Medicaid covered services. And especially in Vermont, because our Medicaid cover services are a little bit broader than in other states. And so we actually, some of our Medicaid rates are above that of Medicare because we want to incentivize the utilization of those services. Some of them are much lower. So we're always kind of looking at this balance to see how far away are we from the Medicare rates. But we could certainly talk more about the history about how we arrived there. Again, that would be a great question for Alicia Cooper at DEVA.
For what it's worth, I did Google it and it said that we first got the 1115 waiver in September 2005. which allowed flexibility in how we manage the program. It has other details. So that's what what I was trying to understand is it sounds like for 20 years, Vermont has been allowed to be flexible. The question is, how long has reference-based pricing been used? And that's not essential for me to know right now, it's just a curiosity. When you've said, I've heard this before, and then you reiterated that we're already doing it for Medicaid and so I just wanted to understand the mechanism that allows that. And it's not that all states are doing it, it's the waiver that allows us to do it. Okay.
Yeah. And when Alicia was here last week, we looked at a table that had a number of services and then their reference fees. To Monica's point, I know we spent some time on that table because you all thought it was interesting. So I just wanted to say that, and then I'm going to say something else that you can correct me if I'm wrong. But I think right now, DIVA uses reference-based pricing and has for many years, as we're talking about. We are implementing a Medicaid hospital global budget this
In 2026.
January. So I just want to clarify that we have been using reference-based pricing for several years within DIVA. We are implementing a Medicaid hospital global budget for the first time this coming January.
No.
Can I just add something for context?
Yes.
For the record, Noel Langell, Joint Fiscal Office. For as long as I've been here, there have been conversations, and I've been here 18 sessions. There's been conversation about how do Medicaid rates compare to Medicare. That's always been the conversation, it just wasn't called reference-based pricing, just for context.
Is this the table you were talking about?
Yes.
Thank you. I found it.
Any other questions? I know it's not in the sections that we've even started delving into yet, but weaved into 3 through 6 is a lot of talk around the statewide healthcare delivery plan. Two questions. The statewide healthcare delivery plan within this in S-126 seems to build upon the work of Act 126. Number one, how's it going with Act 126? Or I'm sorry, 167. 167. S-126, Act 167. How's it going with that? What's the timeline for finishing that? I think we're going to have some testimony next week, but based upon the experience of implementing 167, do you think the timeline on this statewide health delivery plan is achievable so that all the things in section 2 through 6 can actually happen? So I guess a 2-part question.
Yeah, and both are great. So, the first thing you asked was kind of how's it going? I think we learned a lot, AHS, just speaking for us, through the Act 167 work. I had the privilege of participating in that pretty closely on the steering committee with GMCB and additional partners. And, we think of Act 167 as, and the output of that by way of the Oliver Wyman report as a menu of options for us to consider. We've seen some hospitals, some healthcare partners, certainly AHS, look at what those recommendations were and say, okay, what's the feasibility here? Where would we really get the greatest return for our Vermonters on the investment of making this change? I think there's a lot to consider in there, but that's part of what Act 51 was, and sort of compelling the Agency of Human Services to carry forward the transformation work. And so we've been working on that very closely with Green Mountain Care Board, Healthcare Advocate, other partners. And, we've identified pretty quickly, and I think you heard testimony to this point earlier this week, that the transformation work doesn't necessarily happen fast. So what we're doing right now is we're taking all of our Ryan report, other things we know about what needs to happen in Vermont, and really putting forward a future vision of what our healthcare system should look like in Vermont to meet our current needs, but also to really take into account what our aging demographic looks like and what we anticipate our future needs are. Because we know that right now what we're doing isn't necessarily working, not necessarily fully broken, but we're heading in a really bad direction, which I don't need to tell you in terms of our financial sustainability and affordability of our healthcare system. So, and I say that with sensitivity because I know there's a lot of healthcare, I'm a nurse, there's a lot of healthcare providers out there working really hard right now. And I don't want to make it sound like any of this is their fault. So what we're doing is setting course of vision and a plan to get there. But it's going to have to take buy-in from all the healthcare providers. It's going to have to take humility. It's going to have to take honesty. It's going to have to take a bit of an awakening to say, this is where actually maybe we're part of the problem. And this is where actually we could be part of the solution. But that can't happen just hospital by hospital, health area, service area by health service area. It really has to be a statewide approach. Because if we break something over here and don't have visibility into the impact over here, we just create more mess. So the transformation work has to be thoughtful, and it has to be inclusive of a lot of organizations and input. So I'm really excited to share more about that as we're fleshing it out. We're working with an incredible contractor who already has a good trusting relationship with the hospitals. They're showing up. Every single one of them has bought in and is engaging with us. And there's also some acute, critical short-term needs that need to be addressed, which I know you've already heard about from Chair Foster. We support the need to make some changes in the very near future, so that we're not facing the rate increases in the commercial space, commercial insurance space that we know are in front of us. And so again, this work has all been really collaborative, but we're realizing there's the transformation work that is going to be sort of some like medium and longer term change, and that there's this acute need that needs to be addressed as well. So overall, feeling good about the partnership, the work, the buy-in, but we're on the precipice of having to make some incredibly challenging decisions. Rutger?
Can you talk about some of these incredibly large changes that you're thinking about?
Yeah, I would really refer to the some of the recommendations that were in the Oliver Wyman report, but we know that there are certain services you need close to you. Everybody needs to be within 30 minutes of, I don't know what the it is, but let's just say
Yeah.
you need to be within 30 minutes of an emergency department.
Yeah.
But do you need to be within 30 minutes of a different type of service that maybe you wouldn't need to use in an acute situation? And how does our state situate itself in terms of its healthcare structure to meet those benchmarks and those needs so that people can access what they need when they need it? Not necessarily what they want, where they want it, when they want it, but really thinking about needs, what is actually critically important for people to be able to access in our healthcare system. And we're trying to figure out how to right size that. And it might mean making changes because maybe our transportation needs to look a little bit different in order for people to access the healthcare services that they need, because it might not be as close to them anymore. There's a lot of implications for these changes, and that's what we're trying to map out really thoughtfully, and in partnership and collaboration with our hospitals and our designated agencies and our home health agencies, who we're going to be leaning on even more than we do now.
And so in the bill, it talks about the global budget, and it talks about a pilot of 2 hospitals. That sounds like a lot of structural change to me, which I agree with, by the way.
Yeah.
Has to get done.
Yeah.
And earlier in your testimony today, you talked about getting that global budget piece done sooner. Would that include the structural change that would have to go along with that to reduce the cost?
It is our opinion at the Agency of Human Services that hospital global budgets
Yeah.
implemented sooner would be beneficial to the healthcare system in terms of a cost control lever.
Mhm.
I am,
The delivery of services part. How about the delivery of services part? You mentioned, you referenced the emergency room. I'm with you 100%.
yeah,
Delivering those services in a different way
yeah,
in a region.
yep.
Is that in your thought process?
I mean, always. Yeah. I mean, these things are really interconnected, right? You know, we want the payment to incentivize the right thing. We know providers are really trying to do the right thing for their patients. That should be where their focus is. Our job as the system folks behind the scenes should be making sure that we're incentivizing what's necessary and what's needed So absolutely, it's always the delivery of service and the quality of the healthcare always goes hand in hand in how we're trying to pay for it. And it takes time, right? Like, yeah, kind of got to try it and adjust and check and adjust over and over and over again because things change. But yes, that's always in the forefront of our minds. Again, I said out front, I'm a nurse, so I'm always thinking about the patients. It's just where my brain goes. So always, yeah.
Good, thank you.
Mike, did you have a question?
I'm just curious to know how you apply quality measures in your reference-based pricing model.
Yeah. So it's a great question, and I'm not the expert, but there's quality indicators that are required for our Medicaid program. And so those include things like access to care. They've included lots of different metrics over time. Drive time was one at one point. So we measure them, we monitor them, we report them to CMS. It's part of our requirement to ensure that we are maintaining quality assurances, patient experience. These are all measurements that are included within our Medicaid program that we report on quarterly.
So there are process measures and process measures and outcome measures. Do you do both of those?
We do.
Is that something we could see?
It's a good question. I have to look. I mean, there's no secrecy to it. It should be a manner of how we could portray that and share that.
I think it's really interesting because that's what we want to move the system to.
Yeah.
So where where you
Appreciate that.
are, current state, what are you measuring?
Yeah.
And is that, the incentives, because you talk about incentives, are
Yeah.
these the right incentives? Or, right, I don't,
Right.
I can't say
Yeah.
obviously,
Yeah. I
but
appreciate that very
Yeah.
much.
Yeah.
No, quality should be in, making sure that the outcomes that we're trying to achieve and how we're measuring that, how we're holding ourselves accountable to that. It's really important.
yeah, so
Absolutely.
I'm wondering if we can include that somehow, that we see those. I'm gonna think about that.
It would be part of the, so when we come in to
Safely.
talk about 8 and 9, I think that would be a really great place for us to dig into a bit more.
That's great, thank you.
Great. Well, thank you for coming in.
Thank you.
And yeah, Jessa.
Good morning. Thank you very much for having me back in on 126. Jessa Barnard, the Executive Director of the Vermont Medical Society. And I know you know who we are, but I do just want to highlight that our perspective as a whole on the bill being informed by our members who are the individual clinicians in primary care as well as specialty care and across all different settings. So really not just the lens of one type of location, one type of practice, but across the range of healthcare systems. And we've heard a lot from our members over really, I give credit to the Oliver Wyman report process of really engaging not just individuals, but clinicians in what reform of our healthcare system might look like, and also the impacts of changes we're making in certain areas, how that impacts other areas of healthcare. And overall, I really appreciate going right after Monica. She literally took some of the words out of my mouth, which is how can we use some of our payment systems to incentivize the type of care we all agree on are critical for access, prevention, primary care type services. Because I think some of our reform efforts in Vermont, while really well-intentioned, have been somewhat blunt instruments. And so I think some of the metrics that the Green Mountain Care Board looks at are also a little bit of blending issues that we think might be better regulated independently of each other. For example, cost and volume. Because when we're regulating them together in a net patient revenue type metric, I think it blurs really important distinctions. So I'll get into some of the details in the language of the bill. So again, how can we, and I think it's a little complicated in the bill because the bill talks about a lot of different types of payment, reference-based pricing, whether we're moving towards, whether we're going to call them global budgets or global payments, total cost of care. But sort of big picture, our feedback is how can, whichever of those measures we're really focusing on, make sure we're not disincentivizing inadvertently things we want to see more of: primary care, mental health services, substance use disorder services, OB services. Some things we actually want volume in. Volume is not always bad. And in fact, from the 2022 report from DFR, a couple of years ago, we were actually really focused on lack of access and wanting to increase volume. So we don't want to make sure we're asking the healthcare system to solve one problem that on one hand, but then on the other hand, kind of penalizing for actually increasing that access. I know I already testified on sections 2 and 3, so I won't go into a lot of detail. I did include a little bit more written, some granular written feedback on those sections. I do want to mention, because more testimony has come up subsequent to when we testified, we agree, and I think the board said this, so I don't want to put words in anybody's mouth, some flexibility in terms of what benchmark is selected. So I know we've been talking a lot about Medicare, but that is only, again, really one possible benchmark. And you heard, I think it was the gentleman from Brown was saying, there are services where actually it may make sense to use a different, that Medicare doesn't pay a lot of, even if they do have it within their fee schedule. So other payment models like public option plans or workers' compensation plans, which use set fee schedules, benchmark to other things like a blended average commercial rate or a percent of Medicaid versus Medicare. So I think giving some flexibility, I think that the committee could think about ways of asking the Green Mountain Care Board to look at, setting prices or costs of services that don't necessarily limit it to one benchmark. And we would support that flexibility.
Yeah, Tupper.
Could you just explain a little bit what you mean by public option?
Yeah, so states that have, some states have in their exchange a plan that the state offers itself. Not just to say, like in our exchange, we have commercial payers, Blue Cross, MVP that offer those plans. There are some states that actually offer their own plan that they have designed. They've set the benefits that are covered. They've set the rates that are paid. They fund it, taxpayer funded kind of public option, health insurance option. And so they've had to design, how do we want to pay for these services? What are the rates we pay? And at least several of them have used a benchmark methodology for doing that. Across the country, almost all workers' compensation fee schedules use a benchmark methodology. They just use different states have picked different models based on what they think makes sense for their state. So whether that's a percent of Medicare, percent of Medicaid, percent of a blended commercial average, there are many ways to benchmark. And I think giving some flexibility to the Green Mountain Care Board and the providers and payers to talk about, for Vermont or for different services, what actually is the benchmark that may make the most sense for Vermont. And maybe the Medicare does, I just don't know if that full research has been done yet. And again, I think the expert from Brown was saying pediatric care, for example. Yes, Medicare does cover pediatric care, but not a lot. So is their rate as accurate or as precise as we would want to see for those services, OB services, things like that? They may not even cover some of the, again, like say substance use disorder services or other things that we would want to make sure we include. So I think I believe I'm hearing kind of universal agreement. Yes, we need to look more closely at what prices are charged or paid for certain services, but I don't know that sort of statewide we have consensus. Yes, this is the right benchmark depending what services we're talking about, which is why there needs to be some more work. And so anyway, just agreeing that some flexibility in that area in the language of the bill, sort of allowing flexibility could make sense. I will go back. I know the committee keeps coming back to that section 5, the E5 on, I do think this section, VMS as a whole supports the intent of looking at, and I kind of mentioned this, if we are using reference-based pricing, how can we make sure there is a prices or again, charges, depending who's being regulated, for that can incent things like primary care services. I believe that was the intent of this paragraph, is to say, if we are setting prices for services beyond the hospital, or I would argue even within the hospital for things like primary care, maybe we should look at a higher benchmark for those sorts of services. I think the language did get a little confusing, and I think there's language sort of later in the bill that may make more sense for that. I also don't know. I don't think we don't have a strong opinion, but we have concern whether the regulators are ready and able at this point in time to move beyond hospital services. It's already such a body of work to take on hospital-based services, and figuring out, again, these questions, what's the right benchmark? Are they working the way we intend? We would recommend perhaps not even including this section at this time and coming back in the future and saying, do we want this to go beyond the hospital walls? Do we want this to go to community services? What services should be included? What should that benchmark be? To me, that feels like a next step project. And I don't know what language exactly. I don't know if we're even really ready for language personally on if we move beyond the hospital, what would that look like? We would, and I know I've shared this concept earlier, but suggest that one thing we are ready for and need to be moving towards, and I think your question from AHS ties in nicely to this. If AHEAD is not happening, I do think we need to be looking more consistently, cohesively, quickly at alternative payment models for primary care. And that's not really currently addressed in the bill. AHEAD includes a monthly sort of primary care payment model, which will help primary care. But if AHEAD is not happening, what will that look like in our state, especially with losing OneCare, which did have those models? So we would like to see some language asking the Agency of Human Services, the interested parties to come together to start designing. I think that needs to start happening soon if we are not going to have AHEAD in 2027.
I'm sorry.
Your comment about taking this piece out.
Yeah.
If we do that, my own personal feel is that we have to look at what's happening outside of the hospital. If we're going to make all this work, we have to look at the system. And if we're trying to reduce the cost of hospital healthcare, that service, a lot of those services are going to have to be outside of the hospital. So we have to look at it.
Absolutely looking at the system as a whole. In my view, that work is happening more in the statewide plan and other sections of the bill. This section is very specific to setting prices for services outside the hospital and actually tasking the Green Mountain Care Board to start, actually, the started out earlier version of the bill, it actually did say Green Mountain Care Board. Now it says AHS. To me, what this language in the bill right now is asking is AHS setting commercial rates, I think, because it's in the section about commercial rates for non-hospital services. I think I do agree with the chair that if we're talking about commercial rates in any context, it makes more sense for that to live with the Green Mountain Care Board. I just don't know that our healthcare system as a whole, the Green Mountain Care Board, the providers are ready to dive into how reference-based pricing would work for non-hospital services. That's a whole lot more of services. Like, what types of providers are we even talking about? Are we talking about only primary care? Are we talking about everyone out there, physical therapists, mental health providers? What are they currently? They have many contracts with many different types of payers. What are they getting paid? I actually think it's more complicated once we start going outside the hospital context. And it feels like a whole nother project to be kind of tasking Green Mountain Care Board or whoever's in the bill with starting to look at this point in time.
And so if the drone is brought in and we change how healthcare is paid for, one of the ways was mentioned, public option. If we bring that drone in and say, maybe this is what we have to do, it can uncomplicate everything.
I think that potentially we are not. Our organization is in support of actually a national single payer healthcare system. That would be wonderful. I don't think that is a whole other bill. I hope that Congress actually would need to fix. So I think I was referring the plans. The public option plans are actually a pretty specific, targeted, really offering on the exchange. It's not a whole new model of statewide single payer care.
So
If we had a whole statewide one payer, that would certainly be easier from an administrative perspective.
about the hospital period right now, hospital healthcare. The rest of 126, I'm focusing in on hospital healthcare because it's the biggest driver of healthcare, the cost of healthcare. So I'm thinking of that in terms of this bill 126, dropping that in.
I'm sorry, can you clarify, dropping what in? Could you clarify?
Hospital healthcare, how we pay for it. How we control it.
Yes. And I think that is the focus, right? Yeah.
Budgets. and-
Yes.
yeah.
Yes.
I think it all can come under that, once we figure out what global hospital.
What that means. Yes. I think we're talking about the same concepts, just with different words. Yeah.
And,
I can tell you what I'm picturing is actually largely one of the functions of our ACO, which was take a chunk of payment from different payers and pay it out in one lump sum monthly payment to hospitals. That is what I have in my head. If that's, but that may not be what everybody has in their heads of what we're talking about. And including the commercial, what would that commercial monthly payment be that covers the hospital providing services to that payers attributed, patients who are covered by that plan for that month? That is how I picture. That's what I think we might be talking about with those sections of the bill. And I think it's important to involve as many payers as possible in that. You've heard testimony from others about that. Like if it's only one payer, it's really hard for the hospital to transform what they're doing in that model.
thank you for that comment.
Yes.
Brian,
Yeah, so I heard you saying that you were talking about AHEAD and how the plan with AHEAD would have been some continuation of maybe what I'll call a global payment for primary care. I don't know if that's appropriate, but like the concept that there's this base payment to support these offices, these clinics. I don't know what term we would use, sites, healthcare delivery sites. I'm curious what it would take, and this doesn't have to be answered today, and if any stakeholder who has ideas can weigh in on this, but what it would take for us to have a backup plan to AHEAD, which is likely going to be the plan, just being honest. Like I don't expect AHEAD to happen. It has health equity in its title, and there are executive orders against that. So maybe some other model will be brought forward, maybe not. But in the meantime, what about the idea of a backup plan? Like what would it take to somehow provide global payments to primary care providers to make sure they stay solvent and can serve people, but combine that with universal access with no cost sharing or little cost sharing? Like, for example, maybe it's some people pay $5 or $10 a visit, but there's not a deductible. Like, and this might be beyond the scope of your testimony, but I heard you advocating for something. And so what I would say is, what would it take for us to give that something, but go a little further? And, and whether that be a combination of a global payment with reference-based pricing for the fee-for-service stuff that may need to be in there, or just starting with global payments and then figuring out the reference-based pricing for the fee-for-service stuff later. But how big of a lift would it be for us to use this as a step towards universal access to primary care, regardless of the behind the doors payer scheme?
I think that's exactly the type of work we are asking a stakeholder group to dive into. And I think the access piece is not impossible to look at the same. I mean, when I hear you describe that, it sounds a lot like FQHC payment model. Yeah. Right. Like they get a bundled payment, an episodic based payment for caring for their patients. It's supposed to cover all of the services they offer, and then they have to guarantee access. So I think there are ways, I hope optimistically, there could be ways to design something like that. But I think we would take a lot more thought in terms of, can we require payers to participate? Which payers would participate? Which practices would participate? What payment would need to be necessary to get to that point? I mean, the AHEAD payment is pretty basic. It's really a monthly payment per patient on top of fee for service. It's a pretty simple payment model. It would be important to help sustain primary care. I think we could keep looking at more than that. And how could we grow blueprint payments or the AHEAD payments to make it a more comprehensive program?
So just to like reflect back what I think I'm hearing is the recommendation would be to task a working group, somebody
Yes.
of stakeholders to come back with a plan, maybe next year, like this bill being a vehicle to assemble the stakeholders, give them powers and duties and a mission, and then have them come forward with a plan or plans for us to consider next year, but that it is not unrealistic that we could at the very least take a step towards universal access that to the patients that also guarantees solvency for the providers. I don't know.
I think that could be a part of what is looked at in this.
Okay.
I think maybe beyond just this plan, like, but yeah, I think personally, I think if there is a group working on this, it could include, how does this help with patient access?
Okay.
I'll keep moving ahead. I know we're
Yeah.
we're getting to lunchtime. I don't want to keep you from lunch. Almost as bad as keeping you from 4 o'clock yesterday. And going home. Oh boy, that's not good.
I must have more meetings.
I'll try to be quick and just a couple pieces to bring up. I did want to come to the discussion and the section 4 around hospital duties. There's been a fair amount of conversation about a lot of data on administrative costs and salaries are reported. I heard the language yesterday, makes sense to me. If this is already being done, no harm in adding it to statute. Our focus is more on section 8.8, which adds to what I believe in my read is a new term called clinical leadership, and reporting on salaries and benefits for clinical leaders. And I don't believe the Green Mountain Care Board currently defines that term in hospital guidance. And in our view, many clinical leaders are practicing clinicians who may also have a managerial role. So I think it is a confusing term. It is a different term than administrative services, which is one they do use elsewhere. So I think it would be difficult to add that in, and I question whether it's really adding more information beyond what they're already getting around administrative roles. An A9 around proposals for supporting community-based providers and workforce needs and social determinants of health. We support keeping this in. We don't believe it requires hospitals to be doing anything in these areas, but it allows them to share what they are currently doing. And we believe it could be important in the budget process to take that into account. If there is a hospital that is doing a lot to support community services, workforce initiatives, that may be something that should be weighed in the scope of their hospital budget. Budget review. So I wanted to mention in section 4, we do believe it is important to allow, again, in terms of going to the point of how do we use our current tools to incent the services we want to be happening. If we are talking about net patient revenue continuing as a metric, we think it's important to be able to exclude primary care, mental health, substance use disorder services, possibly OB services, pieces where we think volume actually should be happening from that measure. I heard the Green Mountain Care Board, I'd be happy to work on them with some language around, I think there was some confusion about the total, including that or not in the total cost of care. Our thought is actually it should be more looking at the total cost of care growth limits or global payment growth limits, that those are, again, the services we want to have happen. How does that, is that considered the same as any other service growth in terms of restraining increased services or increased volume? In E1 in section 4, we support keeping VPQHC, the Vermont Program for Quality in Healthcare, as having a role in establishing or coordinating quality metrics. They are already a statewide expert in hospital quality measures, and we support keeping them involved. We do have some concerns about the reduction in services being reviewed by the Green Mountain Care Board as written. We just think our members have raised whether it's somewhat inconsistent with other asks of hospitals actually to transform delivery, be more administratively efficient, and manage costs. So we support at least some continued work between the hospitals and Green Mountain Care Board to add exceptions or look at what scope of review actually makes sense. And my big point in this section, it's not directly addressed in section 4, but we actually, again, and I'll just say it again, support further work by the board, especially if they are moving to reference-based pricing and or global budgets, to transition away from regulating based on net patient revenue. Again, the fact that net patient revenue combines volume with cost, we agree with looking closely at cost, but I think volume should be looked at, not that volume shouldn't be looked at, but should be looked at differently. and more granularly in terms of which there may, again, maybe services we actually want volume to be increasing. So if we're lumping it together as a whole, it hides the distinction between the two. And we actually I know Devin and I brought some clinicians in the other day who had some really compelling current on the ground examples of how this is hurting the ability of smaller hospitals to transfer patients to larger hospitals, and how that could, yet the patients are still being transferred, still getting the care, but often out of state now. Because if the larger Vermont hospitals are saying we can't take patients, it is putting us over our net patient revenue. We can't accept them. We're closed to transfers. In these cases, they still need care, but they're going to Albany, Connecticut, Massachusetts, where we have no control over cost or quality, and still costing our system, and actually harder for the patient to be going that far. So again, we would suggest disaggregating those measures. And then I will wrap up. I have some points, smaller points on some of the later sections. I don't know if it's going to come up for much discussion, but to me, it relates to a lot of the reference-based pricing conversation. I think section 7 on contracts, I am confused about the intent of this section. I think it is basically requiring a provider to provide a contract to DFR or the Green Mountain Care Board on request. We believe DFR and the Green Mountain Care Board already can request contract information such as rates paid directly from payers. It's a little bit, again, just from the provider perspective, we're not sure why these contracts would be requested or what data the intent here is to get at. Again, if it's about what we are paying payers, paying providers, I think that information is largely available currently. And the contract itself is, as many of you have probably seen, these are 30, 40, 50 page long documents with all sorts of details that we're just not sure that this section is needed or that requirement is needed. So those are our comments. Again, we do, well, sorry, one last thing. So I don't want to necessarily, I don't know that you want me back 10 more times on each section of the bill. So I will say on the, and it's come up a little bit, the ACO capability, section 12. And AHS mentioned this briefly. Some of the, again, the payments to primary care models, some of the data aggregation, collection, simplification that the ACO has been able to achieve have been really helpful for providers, especially primary care providers. So we do support this section and appreciate AHS's ongoing work to kind of look at what has been helpful and what can the state or other partners continue. I think this work would be, there was testimony in the Senate, this work would probably happen regardless of the language in the bill, but I don't think it hurts to put it in here. So thank you very much. Thanks for your time. Have a great weekend.
I will have any questions for Jessa unless
I can
we
contain
can hold
myself.
it. for next-
I'd be happy to we can talk all you want about primary care, universal primary care,
Later.
not in front of the committee unless they want to.
Later.
And in that vein, before we go, last thing I'm going to say, and this is to the committee. So we have heard an awful lot of testimony and we have rolled through this bill. It feels like a million times. In fact, I realize I need a new copy of it. It's dog-eared at this point. I know that lots of people have come to me and said, hey, have we thought about this? Have we thought about that? With all the testimony that we've been taking, I know that there are thoughts, ideas, things swimming around in everyone's minds. And maybe if over the weekend you could, if you have something that you would feel like you would like to see in here, or something that you would like to see not in here, then I would hope you would jot it down and we can start having some conversations of, where we want to amend this. Because, thank you. So that's your weekend.
Thank you.